Morning to one and all. Today my topic is assessment of motivation for substance dependence. So let's see what is motivation. Motivation refers to the driving and pulling forces which result in persistent behavior directed towards particular goals. It initiates, guides and maintains goal-oriented behaviors. It includes biological, emotional, cognitive forces that activate the behavior. It is applied to substance-dependent patients by mobilizing the client's own change in order to change their addictive behaviors. Dr.Javeed and Discrepancy have described trans-theoretical model how to change addictive behaviors with or without formal treatment. So the picture here depicts the stages of motivation, which includes precontemplation, contemplation, determination, action, maintenance and relapse. Precontemplation stage are people who are not considering change in their problem behavior, and they are described as pre-contemplators. They believe in advantages from substance use outweigh its disadvantages. Nevertheless, one may be receptive to information regarding the risk associated with the pattern level of substance use, which may in turn aid in recognizing the risk associated with substance use and in thinking about at least cutting down one's use. Contemplation stage. Here, the individual begins to recognize that the behavior is problematic under an ambiguous situation regarding their substance use. So there will be a decision balance between the benefits of change and the cost of continuing the substance, and the benefits of staying the same and the cost of change. So the patients try to consider the pros and cons of continuing the substance use, comparing, discontinuing or reducing it, with resulting ambivalence about the drug use. They will be having some awareness of problems associated with the drug use. They may be willing to make change but may not know how to make the change, or may not be confident about one's ability to change. So the therapist's role here is tilting the patient's balance towards the side of early change of behavior, thereby taking the individual to the next stage of change. So the interventions help the patient to identify the short and long-term benefits and cost of continued substance use. It helps to find their own reasons to reduce or quit the substance use. It helps to visualize their ambivalence about the substance use on one side and reasons for change on the other side. And it helps in recognizing the strength and ability to change. Next we move on to determination or preparation phase. So here the patient makes a decision and takes an action to change. The patient has resolved the ambivalence here and they are ready to participate in action-oriented intervention. So, one, make a choice from available choices and finalizes a concrete plan of action. So, we move on to action stage. The individual takes overt behavioral steps towards changing, like reducing or stopping the drug use behavior. So, the intervention includes negotiating aims and goals for changing the risky substance use behavior, suggesting the menu of options to choose, helping them to identify the situations likely to trigger, precipitate relapse, or discussing the plan of action to stop or reduce the substance use. Maintenance stage. After a period of intensive therapy in this stage, people make changes in behavior to sustain their planned action and work to prevent a relapse. They can be assisted to avoid circumstances where they are at possibility of relapse, or to help them progress forward after a lapse of substance use. Termination or relapse. So successful observance of maintenance leads to recovery. But failure in maintenance levels leads to recovery relapse. Actually, relapses are common and we must be prepared to deal with the relapses and encourage the patient to prevent and effectively deal with the same by reassessing motivation and barriers. So we can plan stronger coping strategies here. Let's see what is motivational interviewing. So it is a technique used to motivate the patient to change his or her maladaptive behavior. The therapist here rely on empathy to convey understanding, provides support by noting the patient's strength, explores the ambivalence and the conflicting thoughts or feelings the patients may have about the change, and guidance is provided in the interview by imparting the information about the issues like alcoholism, while at the same time getting the patient to talk about the resistance to altering behavior. It has been used effectively in patients with substance use disorders to get them to join Alcoholics Anonymous. Helps to change the lifestyles or to enter psychotherapy. It has potential to combine diagnosis therapy in single interview with the patient and can be applied to a wide range of mental disorders. So, 5 specific skills are used in motivational interviewing. So, it has an acronym OARS. So, O is open-ended questions, A is affirmation, R is reflective listening, S is summarizing, and E is eliciting change talk. So, open-ended questions provides insight into client's perspective. We can ask about the concerns, benefit about the use. Example, how do you feel about the substance use? What do you know about it? Affirmation includes the statements suggesting appreciation and attempts at understanding the patient's problems and perspectives, in which it helps in establishing the rapport. This helps in building the confidence and boosting readiness to change. Reflective listening involves the use of statements reflecting the patient's underlying meaning and feeling as well as the words used by them. So it is used to emphasize ambivalence about one's substance use behavior and concerns to reinforce statements that indicate the patient is thinking about the change. Summarizing is putting all together and convey them what has been said during the discussion and prepares the patient to consider the change. It enhances the power of reflective listening. It helps the inclusion and emphasis on certain issues over other. Eliciting change talk helps in resolving the ambivalence and helps in enabling the patient to present arguments for change. It also recognizes the advantages of change, expressing the optimism about the change and expressing the intent to change. So patients are encouraged for clarifications and elaborations regarding their statements and their goals. Goals and values are explored to find the discrepancies between the values and the current substance use. Motivational enhancement therapy. So it is the initiation here, the initiating, executing, and sustained change in persons with substance use disorders. It involves it is listening rather than telling. So Miller and Rowling have directed 5 principles which guide the practice of motivational enhancement therapy. It has an acronym DASH, where D is developing discrepancy, A is avoid argumentation, R is roll with the resistance, E is express empathy, S is support with self-efficacy. So motivation enhancement therapy has 3 phases. In phase 1, there is we build the motivation for change. In phase 2, we strengthen the commitment to change. In phase 3, follow through the strategy. So in building the motivation, we elicit the self-motivational statements from the patient. We listen with empathy, and questioning is done. Presenting with feedback, personal feedback, we affirm whatever they say, and we handle with the resistance and reframe or summarize in total. Then we move on to the phase 2, where we recognize the change of readiness, discuss the plan, communicating free choice, we discuss the consequence of action and inaction, and we emphasize on abstinence, and we deal with the resistance. Here, a change plan worksheet is made, and we recapitulate everything, and we also ask for commitment. In phase 3, follow-through strategy is followed. Here, we review the progress, renew the motivation, and redo the commitment. So, developing discrepancy has 5 R's. Here, the 5 R's include relevance, risk, rewards, roadblocks, and repetition. The relevance is asking the patient about the personal relevance of quitting the substance, and risk is asking the patient about the potential consequence of using the substance. Reward is the potential benefits of stopping the substance. The roadblocks are asking the patient about the barriers in quitting the substance and the elements in the treatment that may help in handling the barriers. Repetition is motivational interventions. It should be repeated, repeated every time to the unmotivated patients who visits you. Avoid argumentation. So argumentation tends to evoke resistance. So no attempt is made to have the patient accept or admit the diagnostic label. Employ strategies to assist the patient to see accurately the consequences of drinking and devaluing the perceived positive aspects of alcohol. So reframing can be used. Reframing is a strategy by which the therapist invites the patient to examine their perceptions in new light or reorganized form. Roll with the resistance. So MET strategies do not meet resistance head on, but rather roll with the momentum, with the goal of shifting the client's perceptions in the process. So new ways of thinking about the problems are invited but never imposed. Ambivalence is viewed as normal and not pathological and explored openly. Express empathy. Patients' freedom of choice and self-direction are respected. Only patients can decide their change in their thinking and carry out their choice. We have to compliment rather than denigrate and build up rather than tear down. Persuasion is gentle, subtle, and always with an assumption that the change is up to clients. Support self-efficacy. Support self-efficacy in essence is the belief that one can perform the particular task. The specific belief that they can change the drinking problem, and it is the ability to change is emphasized in the therapy. Unless this element is present, the discrepancy crisis is likely to resolve into defensive coping to reduce the discomfort without changing behavior. Take home points. So the stages are pre-contemplation, contemplation, determination of preparation, action, and maintenance. So in pre-contemplation, people they do not consider change at all. In contemplation, they acknowledge that there is a problem. In determination, they make a decision to quit the alcohol and do something about it. In action, they take an action to stop the drinking behavior. Maintenance, they sustain the modified behavior of drug-free living. So, what we can do is in pre-contemplation, we can avoid confrontation, educate about the alcohol and drugs, and focus on rapport building. And we can encourage and appreciate on any expression of desire to quit the alcohol. In contemplation, we can facilitate the analysis of pros and cons and helps in realistic appraisal of the good and bad things about doing the alcohol. In determination, we can reaffirm the patient's ability to make the change. In action, we can help him to lay a definite plan of action. And in maintenance, we can try to involve a significant other. So in MET, we should de-emphasize on label and acceptance of substance use. And we have to emphasize on personal choice regarding the future use of substance. So the therapist conducts objective evaluation but focuses on eliciting the client's own concerns. Resistance is seen as interpersonal behavior pattern influenced by therapist behavior. Resistance is also met with reflections. References. Kaplan and Sadaf. Synopsis. Morgan and team, and MET manual on enhancement therapy. William R. MET manual. Prochaska and DKMT. Applications to change addictive behaviors.